In this section, we'll take a 50-year trip on the development of the treatment of wet age-related macular degeneration in just 15 minutes. In the 1960s, before the invention of fluorescein angiography, we had clinical descriptions. One of these was disciform macular degeneration. If you also do a literature search, you will also find the term senile macular degeneration. This was used as opposed to juvenile macular degeneration. However, at that time, Alzheimer's disease started to become more prominent, and therefore the term senile macular degeneration was changed and became age-related macular degeneration. Fluorescein angiography was first developed in the 1960s, and with that, we began to understand the vascular pathogenesis of the disciform or the neovascular age-related macular degeneration. Here is a color and a fluorescein angiogram of a classic type 2 choroidal neovascular membrane. So with the understanding of the vascular nature of wet age-related macular degeneration, the macular photocoagulation study was instigated to see how effective was laser cautery of the new vessels. First, the eligibility to be entered into the macular photocoagulation study was the patient had to have drusen, signifying that this was an age-related process. Secondly, the vision had to be 20/100 or better. And finally, there had to be angiographic evidence of a choroidal neovascular membrane no closer than 200 microns from the center of the foveal avascular zone and no further away than 2,500 microns. Here's an example of one of my patients. This is an 85-year-old female who had had distorted vision for 1 month. The vision in the right eye was recorded at 20/50. The top left photograph is before the laser. You can see the gray-green type 2 choroidal neovascular membrane. The mid-phase fluorescein angiogram is next to that, showing the hyperfluorescence and the typical hypofluorescent ring around the neovascular membrane. The bottom left is 6 months after the treatment, and her vision was 20/50, and the bottom right fluorescein angiogram shows non-filling where this membrane was treated. The macular photocoagulation trial and recruitment was stopped after 18 months because 60% of the untreated eyes had suffered severe vision loss compared to only 25% of treated eyes. Well, if this was so good, why do we no longer use argon laser for neovascular membranes? First, of all the people who were recruited for the study, 88% were untreatable. They either had a subfoveal neovascular membrane, there's a pigment epithelial detachment, there was retinal hemorrhaging, so the nature and the extent of the net could not be seen, or there was a type 1 occult choroidal neovascular membrane where we did not know the extent of the membrane. Also, of the 12% who met treatment criteria, central vision was only preserved in 50% because of recurrent membranes. Here is an example of another one of my patients who started with vision of 20/50. However, 4 months later, the membrane recurred and the recurrence is now subfoveal. So, while laser photocoagulation did work, there's only a small subset of patients for whom we could preserve the central vision. In the early 2000s, photodynamic therapy was developed. We injected verteporfin intravenously. It was attracted to the immature endothelial cells, i.e. those growing in the neovascular membrane. The wavelength of the laser activated the porphyrin, and that destroyed the vessels from within. The first classic trial for verteporfin was for subfoveal classic choroidal neovascular membranes because we did not have any treatment for them. Here is an example of a patient with a choroidal neovascular membrane, which is subfoveal, and the result 3 months later. You can see the pigmentary changes and the scarring on this patient. The first trial was called the TAP trial, T-A-P, the TAP trial, and it compared the natural history of subfoveal classic choroidal neovascular membranes with photodynamic therapy. You can see from the graph here the 3-line vision loss with these lesions. The vision loss was reduced from 68% in 2 years without treatment to 53% with photodynamic therapy. Each photodynamic therapy was long-term successful only 10% of the time, so most people needed retreatment every 3 months. The very first anti-VEGF medicine was called Macular. It selectively targeted only VEGF 165. It slowed the loss of vision but did not stop, and people did not get better. It was on the market for only about 1 year. The Marina trial reported the results of the first non-selective anti-VEGF inhibitor. With the approval by the FDA for ranibizumab on August 1, 2006, the treatment of neovascular macular degeneration was revolutionized. We now had treatment options which did not involve destructive laser, and it was the first time that central vision not only could be preserved, but actually for a time the vision could actually improve. The Marina trial studied the treatment of occult choroidal neovascularization. Occult lesions were chosen because there's no proven therapy for any occult lesion at the time. And the Marina trial showed the treatment was far better than the natural history. And here is the graph of the Marina trial. After 2 years of monthly ranibizumab, they found that there was a 90% chance of preserving the central vision as opposed to the natural history of only 53%. And most people lost a significant amount of vision without treatment. Now, as you recall, the TAP trial for photodynamic therapy was for classic subfoveal choroidal neovascular membranes. And while the results weren't great, they were better than the natural history. Therefore, because PDT had been shown to be better than natural history, the next study was to compare anti-VEGF with PDT, which was the accepted treatment for subfoveal membranes at the time. And you can see from the result here that the anti-VEGF was significantly better in the 2-year visual results than photodynamic therapy. Not only did the anti-VEGF injection protocol reduce vision loss, but it also showed that 34% of the patients could actually improve their vision. And here is a bar graph showing those results. So with the results of the Marina and the Anchor trials, we could now treat both type 1 and type 2 choroidal neovascular membranes, and we could treat them whether they are subfoveal or elsewhere in the macula. Finally, there's a potential for a 30% visual gain, which we had not had before the anti-VEGF treatment, and however, there's still a 5% chance per year of severe visual loss, even with monthly treatment. Monthly treatment is a great burden on the healthcare system, socially, patients, and their family. But the question is, what happens in real life long term? The Horizon study was a 4-year extension of the Marina and Anchor patients. And you can see that after the study finished, the vision, which is the top line, gradually worsened and got back to baseline. And in retrospect, when they looked at this, they found that if the patient kept on their monthly dosage, the vision remained fairly stable. However, those that did not keep that strict protocol, those were the patients that tended to lose more vision. So a further extension of the Marina Anchor and Horizon studies was the 7-Up study, and that was published back in 2013. And they found that at a mean year of 7.3 after the initiation of the intensive treatment, about 1/3 of the patients had visual acuity of 20/70 or better, but there's a significant number of people who had vision that was less than 2200. And again, it was the stopping the regimen that led to the most severe visual loss. So we do have a number of studies to try to see if we do need to do monthly or can we treat and extend. So the first study was the Pronto study. After 3 months of loading injections, they would then retreat if the visual acuity declined by 5 letters, or if the OCT showed evidence of fluid in the macula or is increasing, if there's a new macular hemorrhage or a new area of choroidal neovascular membrane. And then the patients would get a treatment. And in the study, they found out that the mean number of injections was between 5 and 5.6, and the vision results were equivalent to monthly. However, the patient still had to come into the clinic every month for an exam and an OCT. So there's still a great burden on you and on society for these monthly examinations. So there are a number of other studies that tried quarterly injections after the loading dose. One was the PEER, the other the Excite, and the other was for G-Man for bevacizumab. All of these studies showed initial improvement of the vision for the first 3 to 4 months, but if they went on to quarterly, all of these showed loss of vision. So we have had development of more anti-VEGF treatments and also biosimilars, and some of these propose that they can go out to as long as 4 months and still keep the same vision. However, we do not yet have any 4, 5, 6, 7-year studies to show whether these results will hold up over time. You may want to not risk extension, especially if patients are monocular or if they are on anticoagulants. We cannot predict when someone may bleed with a recurrence. And if the bleeding does occur, if the patients are on aspirin or other blood thinners, the bleed is larger and the loss of vision is more than if they are not on anticoagulation. Also, you may want to take the chance of extending if the vision is 2400 or worse. You know the scar tissue and pigmentary changes, and they will not get better. So you may want to say, well, quarterly can maintain the vision, but I know it's not going to get any better. So you can possibly extend if they have already lost the center vision and do not have hope of regaining any of the center vision.